Okay, so we will continue with stimulation, electrical stimulation, because this is also part of the orthopedics content that we would like to make sure that we understand. Now, last time when we talked about the electrical stimulation here, do you remember what we said about the effect of electrical stimulation on bone in general? Minimal in bone formation, but it was useful if we would like to make cartilage, right? So and also extracellular matrix. So these are the things that we've noticed that when we do electrical stimulation on the bone, that's what we have. And also we talked about two ways of the stimulation. You will have direct stimulation, which is inside the bone, or you have capacitive coupling, right? Which is outside a cast or outside the skin. And that's how you get the bone formation to do that. Does it make sense? We'll have a look at those now. But for bone is hard tissue. So the idea behind any medical intervention is actually to make more bone, correct? Now, here's the tricky part. We're not going to do any of these interventions unless we have a medical problem. So if a subject has a fracture and they're healthy, we're not going to intervene. We intervene only if the subject has osteoporosis or diabetes, or we have something called non-union or delayed union, right? So the union of the fracture, if it's healthy, should take, probably 2 to 3 months, we should be good. But delayed union is something that is taking more than 6 months to heal, and non-union that you have 1 or multiple years without a proper healing via X-ray. So then we use these interventions. So we talked last time about the electrical stimulation. For the orthopedic ultrasound stimulation, it's orthopedic medical devices. We talked about plates and screws, right? And now we would like to talk about this technology, which is really important. And I feel that it can be used actually more and be more productive and useful. So here's what we would like to look at. We have something called, remember we talked about PEMF, pulse electromagnetic field, right? That's the electrical stimulation. Here we're going to do something called pulse low intensity ultrasound, PLIU, pulse low intensity ultrasound. It's used, the only thing that is used for fracture repair. And so what is the definition of an ultrasound? Remember, the human body actually respond very well for anything that is pulsated. That's why it's the PEMF, the pulse electromagnetic field, and the pulse low intensity ultrasound. We need to have these bursts. Our cells and body reacts way much better for pulsated stimulation compared to continuous stimulation. And that is actually across the board. Does it make sense? Even with light. So anyhow, we will focus on electrical and ultrasound. So what is the definition of ultrasound? It's a propagating pressure wave that transfers mechanical energy into tissue, right? Now, we have found that we have some cell types that they have something called mechanotransduction. So what does that mean? Mechanotransduction means that the cells will feel the mechanical vibration or pressure, and they will react based on that vibration. Now, when I say react, what does that mean? React means that the cells will start producing proteins or do something called phosphorylation that will stimulate upregulation or downregulation of genes. So if I want to simplify this, so look at that. So let's say I have a cell, right? And we say this is a cell that has mechanotransduction. These cells are bone connective tissues, so that bone and muscle. Does it make sense? Those we call mechanotransduction. So these cells, they have receptors in their phospholipid bilayer, correct? That's the membrane. These receptors will feel the pressure. Once they feel the pressure, what happened to them is that we will have something called phosphorylation inside the signal, inside the cell. So you will have pressure outside, right? Cells will feel the pressure. Some receptors will be phosphorylated inside. This is called a signal that is transducted from outside to inside. Make sense? Now, other molecules here will see that we have some phosphorylation. Once they see the phosphorylation, they will move to the nucleus here, and then they will start the cascade of DNA transcription. So if they want to make more bone, the signal will come, well, start making the messenger RNA to start making hydroxyapatite and stimulate doing the bone. If you want to make cartilage, that's what they do. And that's what we mean by mechanotransduction. Does that make sense? Now, not all cells do this. Special types of cells do that, the mechanotransduction, including bone cells, which are the osteoblast and the osteoclast and osteocytes. Do you know the difference between what's osteocytes? It's an osteoblast, bone-forming cell, but it was buried under the bone. So it becomes, slow and dormant. It's not going to do much unless we have a fracture or some other stimulation. right? All of these cells respond to mechanical stimulation. Now, pressure waves are actually really, really good in stimulating cells, but to do this mechanotransduction, but we can't have high intensity ultrasound. I think high intensity ultrasounds are used for imaging. When they look at the babies, that's what they do. We need low intensity ultrasounds. Are those the things that can actually stimulate mechanotransduction? Now, it depends. Different frequencies, different magnitude of this will stimulate different molecules to upregulate or downregulate. We can have a signal to stop producing a specific protein. For example, osteoclast cells will stop actually making, usually they stop making acids and proteoglycans to dissolve when they have ultrasound, right? Are we good with this? With the whole thing? Now, here's the thing. And also, you remember we talked about this before, that if you have something that low concentration or low intensity and something at high intensity, the one that's usually high will give us a negative result, something we don't need. So you need to find out which frequency work and which energy and how much. So when I say frequency, say with pulse, so how fast that pulse is, and the intensity, how large the energy transfer when you have the vibration. Does that make sense for that? Cool. So what do we have? Signal can be absorbed, propagated, or reflected. Remember from physics? Like light. Ultrasound, and that's how we do medical imaging in ultrasound. If you have two different, let's say the brain and the skin, so the skull, because of the reflection and propagation of ultrasound, you will be seeing different intensities, different colors. We give the different grayscale for those. So signal can be absorbed, propagated, or reflected. High energy and intensity ultrasound is absorbed by tissue used to heat them and kill malignant cells. So yeah, if you, high energy, low intensity is the one that is good for stimulation. But if you put it really high intensity and energy, you generate heat, and that's what we do to kill cancer cells. Now, people like to do chemotherapy and radiotherapy because they want it to be fast. But actually, ultrasound is a much better approach, especially when you are around sensitive, organs in the body. That's good. So that's another thing that's used. We are not going to use high intensity. You can have low energy. I think low energy, high intensity for imaging, but high energy, high intensity is the one used for cancer therapy. Now, our job as engineers, we design these transducers, right? This is our device to design. Okay, low intensity ultrasound typically used for imaging. Yep, I think I was wrong. So low intensity, you always for imaging, but it's not pulsated. It has to be pulsated in order to be used for mechanotransduction. Make sense with that? Yeah, low intensity ultrasound typically used for imaging, but if it's pulsated, and we have different ranges of that intensity, will help us decide which one will stimulate mechanotransduction. So how many applications for ultrasound? Imaging, cancer therapy, and then you have the mechanotransduction, stimulation of bone, right? Bone cells. So information about the pulse low intensity ultrasound. So clinically effective ultrasound signal. It was approved by the FDA, and this is the only setup that is approved by the FDA. So what we say is that you will have 1.5 megahertz wave, ultrasound, but it's pulsated at 1 kilohertz, and you have 30 milliwatt per centimeter square for its intensity. That's energy transferred into the whole thing. So what does that mean is that you will have, let's say, a frequency of, this is 1.5 megahertz, but this is sent, right, on a frequency of 1 kilohertz. So this is 1.5 million cycles per second here, but these two are actually pulsated at 1,000 pulse each second. Make sense? So 1.5 million cycles for ultrasound per second, pulsated at 1 kilohertz, 1,000 pulses per second. And that's how much energy you need to give it to do that. And with this setup, it was found that this is actually very effective in stimulate mechanotransduction, for mechanotransduction. Okay, delivered by transducers, right? We have a transducer. So what is the definition of a transducer? It's a device that transfers one form of energy into another form of energy. So you can take electrical signal and convert it to ultrasound or to light. So that's called transducers, a transducer. Now, we build transducers. I don't think the Arduino kit has multiple transducers except the ultrasound sensor that converts vibrations into electrical signal for the Arduino, right? So that's the transducer. So the ion receiver converts infrared into electrical signal. That's correct. That's a transducer. So we have coupled to skin with water gel. So here's the thing about ultrasound is that it needs a media to propagate with. So we can't have it in the vacuum, right? So that's why we use water or water-based gel. What I did when I did any bone experiments, the team in the lab, they had the rat's femur in water, and we did the ultrasound through water, inside water. And so it's cheaper for us rather than buying a lot of gel, of that expensive gel. And you've seen probably the lady that has ultrasound, they have to have a gel on that thing because you don't need air bubbles. Any air bubble is going to disrupt our ultrasound measurements. So the theory is at high frequency, that's high frequency, 1.5 megahertz, low intensity, which is 30 milliwatt centimeter square, ultrasound signal passes through soft tissue to the bone. That's what you want. You want to make sure that your ultrasound reaches the bone, and then that's going to affect the bone cells, especially when we have fracture. Make sense how they look at that? Okay, so in the 1950s, the ultrasound application on fracture healing began. People start testing that because we learn more about the cells, and I think at that time we learned about mechanotransductions, and there were a lot of theories. So we found that when we do this, we found enhanced callus formation. Remember, the callus is the spherical tissue around the fracture to stabilize it, right? In rabbits and human model were found. So both of them, we have bigger calluses. Then in the 1980s, more investigations took place, and so Duret, he did a controlled rabbit osteotomy model, and they found that 28% acceleration on cortical bridging. Now this is different from what we did in electrical stimulation. Cortical bridging, that's bone, that's hard callus. So that was good. That's really good for bone, for orthopedics. 1992, Wang also reported techniques for closed rat femur fracture. Remember the image that I showed you last time with the femur, and we have the fracture in the middle and the intermedullary rod? That's something we called closed rat femur fracture, because I didn't open the surgery on the side of the femur to break it. We just break it so I have a device that you throw weight on the bone, on the femur, and then you fracture the bone itself. So that's closed fracture. And they found that accelerated endochondral ossification and enhanced strength. When we say enhanced strength, it means that we have more bone, correct? That's hard tissue. Do you know what's endochondral ossification? Any fracture that takes place in long bone, the process for healing is endochondral ossification. And that is where we form the callus. So blood vessels rupture, blood gets out, platelet-derived the platelets in the blood explode, and inside them we have proteins that ask other cells to come to start proliferating to make the spherical callus. So you will have a fracture like this. So let's say you have this bone, right? And it's fractured. Now blood vessels erupted. Now you have blood. The platelets in the blood will explode. Inside them there's something called platelet-derived growth factor. It asks all stem cells to come to the fracture site. So what you have is you have this bone now, right, fractured, but it's creating a callus around it of proliferating cells to stabilize it. Soft callus, all cartilage. Then the osteoblast comes in, start depositing calcium and hydroxyapatite, and then you will have a hard callus. Very hard, and it's usually the long bone, you have the bone marrow cavity in the inside. That's gone when there is a fracture. So then the osteoclast comes in and start remodeling, and to make sure that the bone goes back to its shape. So you will have osteoclast coming in and removing all of that so that it comes back to its place. That's called endochondral ossification, the process, right? So fracture, bleeding, rupturing of the plates, proliferation of cells. A lot of cells will start proliferating to create this callus. Cartilage forms and collagen, and then osteoblast makes bone. Osteoclast comes and reshape the bone, and that's it. Now, the opposite to endochondral ossification is something called intramembranous ossification, which is when someone has a fracture in the skull. We can't have this, sphere in the skull because it will push on the brain. That's a no. So it's a intramembranous ossification. It's a completely different story. But we found with ultrasound that ultrasound accelerates this endochondral ossification. So it goes faster. And remember, we have delayed and non-unions. That's good for us, correct? Because we're accelerating bone healing with ultrasound. And it's stronger. Stronger means that it is bone. In electrical stimulation, it was not bone, it was cartilage and extracellular matrix most of the time. Okay, so mechanical, this is an observation, right? We did mechanical testing, which is using the instrument machine, and we found that the bone is stronger. Now, what is going on? So what is happening that will result in such change in bone formation? So we have the exact mechanism of action till today remains unknown for mechanotransduction. There's a lot of research still going on seeing. Remember when I told you there's phosphorylation and the proteins comes in and goes to the nucleus? This is called signaling pathway. We have a lot of proteins actually acting on mechanotransduction. We don't know what is exactly happening there. So this is another area of research for people to go to. Does it make sense with that? Okay. Effects seem to be focused on acceleration, endochondral ossification. We agreed on that. So it's happening faster. Now, in vitro means in cells outside the body. That's the definition. So rat chondrocytes. So we took the chondrocytes are the cells that make cartilage, right? So demonstrated elevated levels of cartilage matrix protein and messenger RNA. So we have upregulations in the chondrocytes to make more proteins, right? Now, rapid changes in intracellular calcium level with ultrasound. We found also that for these, not just chondrocytes, other cells like osteoblasts and osteoclasts, the intake and outtake of calcium was really quick, and there's big changes inside the cells. So we are affecting something that is affect the calcium intake inside the cells. Does it make sense? And now, more in vitro work. Bone marrow cells. Now, those are the cells inside from the bone marrow. They were influenced by the pulse low intensity ultrasound to differentiate along osteogenic lineage to become bone cells. So the bone marrow filled with stem cells, correct? Now, these stem cells, if you expose them to ultrasound, they suddenly commit to become bone cells, osteoblast, right? And that's a non-chemical differentiation stimulus, which is really good, which is important. So they become bone cells on their own. Periosteal cells. Remember the outer part of the sheet on the long bone? That's called the periosteum. We found that periosteums, if you took these cells and you expose them to ultrasound, they also undergo differentiation into bone-forming cells to become osteoblast. So this is also helpful for orthopedics in bone, that these cells are becoming or differentiating into bone cells, osteoblast. Make sense? Good. Enhanced mineralization and bone formation. We have a lot of hydroxyapatite, which is calcium, which is bone. That's good for us. So that's all in vitro, which is cells outside the body. Now, when we say clinical studies, those are on humans or on human cells. But usually they're on humans. When we say clinical studies, it's a human cell. So a human experiment. So we'll have patients who have fractures with delayed or non-unions, and then we expose them to ultrasound stimulation. So this study here that happens in 1994, so Hickman found that fresh cortical tibia fractures treated with ultrasound. Fresh means that it happens, 2 days ago during surgery. They start fixing the fracture and then start exposing it to ultrasound. They found 38% acceleration in clinical and radiographic union in treated fractures. That's a lot. 40% is a large number in medicine. We are happy when we have 5% for any treatment. Actually, when you get 38, that is a huge difference. And this is one of the most important publications. And then Christiansen in 1997. So this is a journal of joint sport, right? Journal of bone and joint. So that's one of the big journals. So non-operative treated distal radial wrist fractures. So a fracture in the wrist, but it has not been in surgery, under surgery. They also found 38% acceleration bone healing because of ultrasound. Ultrasound is really effective for bone formation. Really effective for bone formation. And that's a playground for us as engineers. What we can do. That's lethal injury. They should be doing this. Physicians want to do surgery, and they don't want to, and also the time. And the other problem is compliance. So let's say the health insurance company, covered the cost of your transducer or device. People usually actually don't use it. So you have compliance, and you have, the tendency to do surgery quickly, and even after doing the surgery. So the problem with someone who is 80 or 90, anesthesia by itself is a life-threatening, procedure. So there's a lot of things can affect that. But ultrasound, 40%. This is all what you need. It's a very effective technology to use. Yep. And Yeah, wrist and foot, it should be ultrasound. Yeah, it's not going to, because the only thing that is, so heart cells, the myocytes, do have the capability of mechanotransduction. But if you align the transducer so that the wave is away from the heart, there are ways to do this. And then you can direct the signal itself. So you can have a transducer actually. So you have, let's say this is my transducer, right? You can direct the signal to be like this or to go like this. So you can control where you want the signal to go. It's with elderly, and also the other thing with elderly people, these things need to be placed for hours actually around the fracture to work properly. And I'm going to show you how much that. But it is an effective technology. But we need the missing part is finding ways to make it accessible and user friendly, right? Okay, now we'll look at patient acceleration in healing due to the pulse was greater in subset of patients who smoked. What do you think that means? So people who were smoking, we found that ultrasound was way much more effective. That does not mean that smoking is good. People who smoke, they have blockages or narrowing of their capillaries, small capillaries. When you have ultrasound, you are actually opening these making sure that more blood flow goes into the bone, and that accelerates bone healing, right? So anything that affects the cardiovascular or blood supply to bone will hinder or delay the bone healing. So ultrasound, people found that ultrasound actually did really well. It was very significant with people who smoke. So the time to union for smokers were less than the time to union for non-smoker patients in a placebo group, because their body is actually, way much more damaged. Their body is damaged because of smoking. Okay, then the FDA did, 3 studies were submitted for the FDA as a proof of efficacy. Remember clinical trials? How many clinical trials we need to do to approve any drug or a medical device usage? 3. Clinical trial 1 is for safety. Clinical trial 2 is for efficacy, and the clinical trial 3 is for long-term safety. So you need to have, let's say, 100 patients for clinical trial 1 to make sure that this is safe as not harming people. Then you get another 100 people to do clinical trial 2. Then you get another 100 people to do clinical trial 3. So proof efficacy is clinical trial 2. So 3 studies were submitted as the proof that it is good for treating non-unions, right? Remember, we're talking about conditions that they are impaired, have impaired healing. So the Netherlands, Germany, USA, that's the paper. I don't want to present it to you. A patient had established non-unions, which means that the physician decided that these people had been fractured for at least 1 year and it's not healing. That's a non-union. Or that let's say there was bone cancer and people had to take a big piece of the bone. And then we say, well, this is non-union. There's no way for that thing to heal. So they put bone cement, and even with the bone cement, it did not heal, right? So the average, 409 non-unions participated in the studies, and the average 21 months since fracture, almost 2 years, and it's not healing at all. The fracture is still open. Do you how much money that costs and time of treatment? And the average 15 months since the previous surgery. So they had a surgery, and it has been a year without any intervention. And if you look at the x-rays, we're still having non-union. And so the patient like this, they actually survive on painkillers because there's no way for the bone to do this. So when they did pulse low intensity ultrasound and no other changes in treatment protocols, more than 70%, for more than 80% of non-unions actually healed. That is huge. That's big. Even though that we have, but this big difference happened because, so it was a result that is happened because the body is really messed up. The metabolism, bone metabolism and healing is really messed up with these patients. And that's what I keep telling people. If you would like to see really big changes, you need to look at cases where it's really bad, and then you will get big results. And that's a beautiful story actually to show how technology can really help in biology. Now the tricky part is that we don't know what's going on. It's working as an observation, but we need more work to see what is happening with the signaling pathways and what is exactly mechanotransduction and how does it work. Make sense with that thing? Now this is an FDA approved device, Exogen, and it's from Smith and Nephew, and I think this is the only one that I've seen used. But I know that there should be more products. This is old. but I need to look more and see which one people are using. But this is the device, very simple. They have the patent, and they have the FDA approval. All what they need to do is to place it on top of the the cast or on the skin, and just push on the button, and this will give them a pulse electromagnetic, a low intensity ultrasound, pulse low intensity ultrasound signal. And the problem with these, they need to be for a long period of time, and they need to be moved each once in a while to around the fracture to be able to stimulate all the cells or around the fracture site. And that's a compliance problem for people to look at. Make sense? So our job is, the future for this type of technology, create more devices for us, and then understand what is actually happening with the signaling pathway. So we know it works, but how does it work, and how can we optimize this for them? Make sense? Yeah. So if you want to be, let's say, a product engineer and focus only on the, let's say, ultrasound transducers for bone stimulation, that's you would go. You can be a product engineer for ultrasound technology for imaging, or product engineer for ultrasound technology for cancer therapy, or ultrasound, product engineer for bone healing or orthopedics, ultrasound in orthopedics. That's how we. Does it make sense? So we have covered so far plate screws for orthopedics, electrical stimulation, and ultrasound. And that's it here. And then we'll start working on the robotics and some other technologies. Now, we will stop talking about the basic concepts. We'd like to go into the devices and technologies now and see what is available, and then how does it work, and get some information and some papers about each one of those, and look at the companies. Good? Any questions? Okay, so let me stop here